Me at the back, or
I can hear you.
you can hear? Okay, I'm very bad at shouting, but I will try to shout so you can hear me at the back. Okay, good. So we're gonna have a brief overview of the femoroacetabular impingement. So I'm gonna keep it very simple. So hip is a ball and socket joint, as we said earlier, with the shoulder, which is the ball and socket joint. The difference between the shoulder and the hip: the shoulder socket is very shallow, so you need a lot of soft tissues to make it deeper. Hip socket is quite deep, so it is relatively or comparatively more stable than a shoulder joint. So you got a femoral head, that's your ball. You got a acetabulum, which is your socket, and then you got a labrum in between. And you got some sort of similarities between the shoulder and the hip, although they are way apart, different. So different types of impingement. So if you look at the ball and socket, so on that side, that's your normal. So your ball and your socket, and normally they will move around, no problem whatsoever. What can sometimes happen, then you can get this, what we call as a cam lesion. It's basically what it is, that if you're looking at the ball and socket from the side, and on the femoral head, just at the junction of the head and neck, you got a bump. If you're moving that in the flexion movement, that bump will catch onto the acetabulum. That's basically your cam lesion. If you go, so this could be the problem, or it could be that the socket is impinging on the head-neck junction. So that's your pincer lesion. So again, or it could be a mixed pathology. So it's very simple. So it's either going to be a cam lesion, or it's going to be a pincer lesion with acetabulum, or it's going to be a mixed pathology with a cam and pincer. So in the pathophysiology, so if patients have labral pathology, then they 90% in one of the studies, 90% they have some sort of underlying structural problems. So they will either have that bump on the femoral head-neck junction, which will cause the impingement and result into the labral tear, or they will have the socket which is impinging onto the neck. Okay, so the problem is the insufficient congruency. So congruency means that the head and socket are fitting nicely. If they're not fitting nicely, then there could be problems. Okay, and again, if they've got hip pain, and because there are a lot of muscles around the hip, so if they haven't got a congruent joint, and then you get muscles working in the pain scenario, then they will cause more problem, and that's the abnormal engagement of your femoral head and neck. So somebody will be presenting with a hip pain. It could be either a young patient or an old patient. Most likely the femoroacetabular impingement is relatively younger patients who are active. So what do? Like anything else, you take a history, and in the history you will look for a C sign. We'll talk about what a C sign is. After the history about the pain, their stiffness or limited activity, then you will do examination. After the examination will be just a general range of movement examination of the hip. Then you will go on to doing the special test, and we'll look at briefly on the special test, and you will have the chance to practice on in the examination session. We'll start in the clinic with a simple investigation in the form of an X-ray. Very unlikely you're going to get a very clear picture of a cam or a pincer lesion on the X-ray, something you do. If you haven't got enough information, then you will go to the further investigation in the form of an MRI scan, which could be either a simple MRI scan, or it could be with a dye, which is an MR arthrogram. By that stage, you will have some idea what you're dealing with in the hip pain. Okay. If you think there's an intra-articular hip pathology before proceeding on to any surgery, most arthroscopic hip surgeons, they will do a diagnostic hip injection to see if there's an intra-articular cause for the pain, which they can relieve with the hip injection. And then hip arthroscopy is an option. So we'll just go through that. So in the history, it will be a slow onset of groin pain. It could be a trauma, it could be without any trauma. It could be increased with activity. Examination will show limitation of the hip motion, and then you will do the impingement test, and they will show the hip and knee when it's flexed to 90 degrees. Then you will try to rotate the hip and see if they've got positive pain. That's the C sign. It's very simple. So they will come and say that that's where it hurts. That's where the pain is. Okay, so that's what we call the C sign. These are the special tests, nothing fancy about it. So again, you will flex the hip and you flex the knee, and you will internally or externally rotate and see if it reproduces their pain. You get an X-ray, which we said, and again, if you're lucky, then you will have quite a big bump at the head and neck junction. This is your cam lesion. This is looking at a different X-ray from a different view. If it is clear or there's suspicion, then you will go to the MRI scan, looking at a normal MRI scan. So the MRI scan, so you can make it as complex as you want. Even with the hip X-ray, you can do hundreds of different measurements, trying to see which alpha angle is, and how deep the socket is. Similarly with the MRI scan, you can make it as complex as you want. Essentially what you're looking at is to see how the anatomy of the hip joint is, the ball of the socket, and also looking at the soft tissue of the MRI scan to see if there is any pathology in the labrum. Again, I have to trust mostly my radiology colleague to tell me if there is a labral tear or not. And again, if you're not clear, then you can give them a dye, and then you get NMR arthrogram, and that's how it looks like. It's just basically more definition of your soft tissue structures in the hip joint. So what are the treatment options? So again, with any pathology, you will start with conservative management, which will be activity modification. If there are any certain movements which hurts, then you're trying to avoid them initially. You can give them NSAIDs and you send them to the physiotherapy. If that fails and you've got an MRI proven documentation that they have an intra-articular hip pathology, then you will offer them a diagnostic hip injection, which is done in theatre under II control to see if that relieves their pain. If it does relieve their pain, then you'll be going for surgical intervention. So again, if they've got confirmed either a bump on the femoral head-neck junction, then you can shave it off. You can shave it off either doing an open surgery, or you can do it with an arthroscopy surgery, with hip arthroscopy. Or if they have labral pathology, then you can either debride the labrum or you can stitch it back. You can do hundreds of other things, but again, those are the bread and butter for hip arthroscopies. So if you're doing a hip arthroscopy, that's the setup. So it's not just come in, somebody come in, so the patient will be in a special table, the legs will be attached, they will be pulled apart, they will need x-ray in theatre, and they need to be asleep so you can do the hip arthroscopy. When you apply distraction, when you pull on the leg very hard, then that's, I don't know how best you can see, but you can see there's a gap, so the hip has been distracted. For the hip arthroscopy is different from the knee arthroscopy. For the shoulder arthroscopy, you can't do it blind by going by your landmark. So you have to do it under II control, and it is usually under Sargent's technique. So you put under the II, you put a wire in, and then you will feed your cannula on top of it. So that's how it looks like in theatre, and those are the pictures when you take it under the X-ray. What you see inside sometimes is this labral tear, and you can either debride it or you can stitch it back. So just a quick overview of the hip arthroscopy, which is lagged behind the shoulder arthroscopy and the knee arthroscopy over a number of years. But again, the first reported hip arthroscopy was in 1931, which was a done 20 cadaveric specimen. The pioneer initially was in 1939 was Dr. Takagi, who did hip arthroscopy in 4 hips, 2 with a Charcot, 1 with a TB and 1 with infection. It was very difficult because the problem was it was quite, as I said, it was a deep socket, tight joint, you can't pull it apart. Okay, so that's why you can't do it until the 1980s when you get hip distraction devices, and that's how you manage to do it. And then 1977 to 1987, a lot of work was done in San Francisco by James Clegg. Number of indications. Okay, so again, you can look at the list, and again, in the hip arthroscopy literature, the indications are going bigger and bigger, so there are hundreds of indications. You should know about the contraindications. So if somebody had an ankylosed hip joint, so hip joint is not moving, you're not going to be able to distract it, you're not going to be able to look inside. Okay, if they've got open wounds, infection, heterotropic ossification, or if they're morbidly obese, you can't get the cannula and you can't get the hip arthroscopy, and you're not going to be able to do it. And again, severe OA. So again, this is not a diagnostic test to look at how bad the hip is in the relatively elderly population, but in younger patients, it will give you an idea about how the state of the hip joint is. A quick mention regarding the epidemiology about the non-orthoplasty hip register. Now this was in parallel to all the other joint registers which have been running in UK and all across the world. So this is a report from 2018. So it was set up in 2012, and again initially there were only very few patients who were added on to the register, but in 2017 over 2,000 patients were entered onto the registry, and at the moment there are around 8,000 patients who are part of the registry. If you look at the surgical approach, most of those hip operations, non-orthotic hip procedures, so they've done arthroscopic, very few open, but a number of them are not recorded. So again, they are working on the registry because it's a relatively new registry, so they're working on it to make it more robust. If you look at the age distribution, so most of the patients, they will be in the younger age groups, and very few patients having hip arthroscopy or in the either end of the age groups. So mostly female, but there are a few men as well. Now, as I mentioned to you, this is the list breakdown of all the established procedures. So the bread and butter is labral debridement, followed by labral repair. But then you can do all kind of different procedures, and at the very end you can do fancy biological surgery to the hip as well. If you look at the femoral procedures, then again cam removal is the most frequent procedure, followed by all the different other procedures. And most of the time working in the hip arthroscopy unit, so you do very rarely you will just debride the cam, is most of the problem is mixed. So not just one camera or the pincer, so the problem is mixed, so you will deal with both of them. So if you've got a labral tear, you will deal with the labral tear, and you also look at the pathology why the labral tear happened, and that might be due to the impingement. So again, there was a lot of criticism over the hip arthroscopy because they haven't got any randomized controlled trials or any good evidence. Last year there was a big randomized controlled pragmatic trial from the UK called UK Fashion, which was published in Lancet, which is a kind of a good quality impact journal. And again, it shows that clinically significant benefit of hip arthroscopy surgery over the non-operative personalized hip therapy. Still, the hip arthroscopy literature is full of case report, case series, personal experience, but there are very few randomized controlled trials, but there are few coming in future. Thank you very much.